We are live, sir.
Okay.
We'll start the program. Am I audible to you?
Yeah.
Ranjith sir, Balachandra sir, am I audible to you?
Yes, very clear.
Yeah, yes, sir. Good evening, everyone. I'm Dr. Chandra Mohan, musculoskeletal and sports physiotherapist and founder of Exercise Testing and Prescription Organization. We are a non-profit organization that provides free online webinars on exercise testing and prescription. We have set a world record for hosting the most free live webinars with participants from 30 countries. On behalf of ExRxIndia, I'm so excited to welcome you all to this webinar. We have 900 plus registered participants from 17 countries that are Saudi, Qatar, Cameroon, Oman, Kuwait, Egypt, Rwanda, Philippines, Nigeria, Bangladesh, UAE, Malaysia, UK, Ghana, Pakistan, Uganda, and almost all states of our nation, India. Here we have Dr. Balachandra, a senior physiotherapist from Trichy and the president of Physio Vision Foundation. Physio Vision Foundation is a registered trust that conducts webinars and workshops to uplift the profession of physiotherapy and professionals. Dr. Balachandra has over 20 plus years of experience in physiotherapy and has a special interest in pediatric physiotherapy. He is a highly experienced and knowledgeable physiotherapist with a passion for helping people achieve their physical goals. I'm delighted to have Dr. Balachandra to be the moderator for this session and request to introduce our resource person. Now over to Dr. Balachandra.
Thank you, Dr. Chandra Mohan. I am happy to introduce our resource person, Dr. Ranjith Kumar Manokaran. Dr. Ranjith Kumar Manokaran is an associate professor in pediatric neurology and consultant pediatric neurologist and epileptologist at Sri Ramachandra Institute of Higher Education, Chennai. He is a board certified pediatric neurologist with over 10 years of experience. He is a fellow of the Royal College of Physicians, SEE Neurology, and a member of the Child Neurology Society of India. He has a special interest in pediatric epilepsy, sleep disorders, and developmental delay. He has authored over 40 publications in international and national journals, and he has edited the pediatric neurology subsection of the book Scott's Pediatric Specialty Series. He is a recipient of the prestigious Johnstone Gold Medal from Madras Medical College for the Best Outgoing Student Award in 2004. I am delighted to have Dr. Ranjith Kumar Manokaran as our resource person for today's webinar. He is a highly experienced and knowledgeable pediatric neurologist with a passion for providing excellent care to children with neurological disorders. I am confident that we will get a valuable insights and information on the topic seizures in children, what a physiotherapy should know. I also thank Dr. Chandra Mohan from Exercise Testing and Prescription for collaborating with Physio Vision Foundation and organizing this webinar in a systemic way. I'm so happy to once again invite Dr. Ranjith Manokaran sir to continue the session. We warmly welcome you, Doctor, for the session.
You have started screen share.
Thank you very much, Mr. Bala. Dr. Bala, can you hear me? And is my screen visible?
Yes, Doctor, it's very visible.
Yeah.
Thank you so much, Doctor.
Yeah. So good evening, all physiotherapists, those who have joined from India. Good afternoon and good morning, those who might have joined from other timelines. So thank you very much to Exercise Testing and Prescription, Mr. Chandra Mouli, for giving us this platform to connect with physiotherapists across the world, as well as to Physio Vision Foundation. And special thanks to Dr. Bala for arranging this, especially for me at my request. So I must say a word of appreciation to Mr. Dr. Bala. He is one of the few physiotherapists I know in the country who is doing excellent job, particularly pediatric friendly and professional service. So I am very happy that other professionals get inspired from him, and they continue to do great job for children who need special services. So for the next 30 to 40 minutes or so, my job is to introduce seizures in children to physiotherapists. This topic was chosen by me because often we see children who are being treated by physiotherapists across the world. These children spend much more time with you than with a doctor, like a pediatric neurologist. So we may see for 20 minutes or 30 minutes in our clinic, once in 3 months or once in a month or so. But you may be seeing these patients very often, and you spend much more time with the family and the child. And often you may experience a seizure while you even do physiotherapy sessions. So I thought it is important to connect through all other allied health professionals who are involved in the care of children who are having epilepsy, so that we can educate them, create awareness, so that you will refer them to proper services, or just advise the families that this is a seizure, you need to see a neurologist or a pediatric neurologist. I am sure you work with a lot of disabled children or cerebral palsy children or children with other neurodevelopmental disorders who may be having seizures. So the goal of today's session is to make you understand what are seizures in children, how do they look like, and how to recognize, and what should you do as a physiotherapist when you see a seizure in a child. So I work in this hospital, which is Ramachandra Institute of Higher Education, which is in Porur, Chennai. And this is a deemed university. And we also have our own physiotherapy and child developmental unit as well. So I'm skipping those initial parts. Okay, now let us talk about what is a seizure. Definition of seizure. Seizure is a transient occurrence of signs and symptoms which result from excessive and synchronous neuronal activity in brain. To put it in simple terms, suppose you see clouds on the sky. Normally, clouds carry electrical charge within the water molecules. For example, I'm equating the clouds to brain. Brain also contains neurons, which contains normal electrical activity. Due to some reason, like a thunderstorm, there is an excessive discharge of neuronal electrical activity, like an excessive electrical activity in the clouds creating a lightning. The excessive electrical activity in the brain creates seizure. So in colloquial terms, it is referred to as fits, or convulsions. But important message here is all seizures does not necessarily fit or convulse. So to put it in Tamil, maybe some of you may not know, ella fitsu valippu, jerk, there are several types of seizures where you actually don't see convulsions happening. You may just see just minor events. So any type of clinical event which occurs paroxysmally, like suddenly in a child, can be seizure. We will see several videos of such examples. So I would encourage the participants to post live questions if possible, and you will have enough opportunity to interact with me. And we are going to show you a lot of videos, and I would encourage you to keep interacting in the chat box. Now, we should understand what is epilepsy. All that glitters is not gold. You know that proverb. Similarly, not all seizures are epilepsy. Ella fitsu valippu noi agadu. For example, in fact, the most common cause of seizures in children is not epilepsy. Does anyone know what is the most common cause you think is the cause of seizure in an under 5-year-old child? Can you see chat box, Mr. Bala, and let me see any responses? What do you think is the most common cause of seizure in a child who is less than 5-year-old?
There will be 20 seconds, sir. Immediately will not get the response. So you keep continuing. Whenever there is a questions, then we will update you in the chat box.
No problem. So,
sir, one answer came from Yogalashmi, sir.
Yes, what's that?
The rise in temperature.
Excellent. So, excellent. So, febrile seizures. Febrile seizures are, in fact, the most common cause of seizures in children less than 5 years of old. And febrile seizures do not amount to epilepsy. They are not epilepsy. Febrile seizures are just temperature-induced seizures which go off once they become 5 to 6 years old. Similarly, several factors can cause seizures. For example, hypoglycemia, low sugar, hypotension can cause ischemia, seizure, stroke, trauma, brain infection, anoxia, that is lack of oxygen. Several reasons can cause seizures in children, but not all lead to epilepsy. Basically, what is epilepsy? Epilepsy is an inherent tendency of an individual to generate further seizures. Put it in a scientific term, we have an organization called International League Against Epilepsy, acronym as ILAE, defines epilepsy as this: at least 2 unprovoked seizures occurring more than 24 hours apart. That means unprovoked means without fever, without trauma, without any electrolyte imbalance, it should happen, and separated 24 hours apart. So just one seizure itself may not be epilepsy. Or you may have just one seizure, but the risk of another seizure over the next 10 years is very high. How do I calculate that risk? I, as a neurologist, evaluate and find out by doing an MRI and EEG and find out what is the risk. And if I feel the risk is much high, I can label that patient as epilepsy. Or at the first presentation itself, you are able to make a diagnosis of an epilepsy syndrome, then also you can label that person as epilepsy. So the message I want to convey here is, not all seizures are epilepsy, but all epilepsies have seizures. That is obvious. So coming to the third point, I want to give you a scenario. Let's see if anybody is able to think. Say a 15-year-old adolescent boy went to a rave party or some late night party, first time in his life, slept at 2 a.m. He also had alcohol, and he woke up around 6 a.m. in the morning, and 7 a.m. he goes to have some toilet and gets a seizure, generalized tonic-clonic convulsions, and gets an EEG done next day, and the EEG shows generalized epileptiform abnormality. Will you call this patient as epilepsy? Yes or no? If so, can you tell me what is this epilepsy syndrome? I understand this is beyond as physiotherapist category, but I'm sure some of you may be knowing this. Is it epilepsy? Yes or no? What could be this syndrome? I will wait for a few seconds, no problem. Yeah.
Check that box in YouTube. And I request our participants to watching it live, make the interactive session, and respond to questions. In case if you have,
Chandramohan,
so you can.
Chandramohan sir, your voice is breaking. Chandramohan sir, your voice is breaking.
Yes, sir. No issue, sir. You please carry on.
Yeah, now it's clear. Yeah.
Now it's okay.
Any responses?
Let me check. Most of the answers are coming as no, doctor. One person answered it is a generalized seizure. Most of the persons are like answering like it is no.
Okay, that's a good attempt.
It's not epilepsy.
That's a good
epilepsy.
That's a good attempt, but this is epilepsy because the patient had one unprovoked seizure precipitated by sleep deprivation, and his EEG showed generalized epileptiform abnormality. That means the chance of recurrence for this patient is high. Even with one unprovoked seizure in this patient, with this scenario, with an abnormal EEG, definite abnormality, I can call this patient as epilepsy, and this is called as juvenile myoclonic epilepsy, which is very common in this age. In fact, one of the most common epilepsy syndromes. So basically, the label of epilepsy has to be given by a properly trained neurologist. So often we see labels like seizure disorder, epilepsy, seizures. So it's very important to give a correct label for the patient because of a lot of implications, starting from social to even personal implications also. So with this message, I will go to what are the concerns. So parents usually ask us, will it happen again? What is the recurrence risk? Could each seizure damage the brain? What is the risk to my life? Should I treat? So let us try to answer all these questions. So in fact, seizures are very common in children. 1 out of every 20 child, that is 5%, can have febrile seizures. And 4 to 10% of children at least experience one seizure in their first 16 years. The prevalence of epilepsy is around 1%, in fact. Incidence is around 3%. So if you take a classroom of, say, 100 to 200 individuals, one of them could be epileptic. If you see 100, say, children in your pediatric physiotherapy clinic, I am sure 10 to 30% of them may be having seizures, because you are seeing a very high risk category group like a cerebral palsy, neurologically abnormal children. So it is very important to understand the prevalence. And often they present with a prolonged seizure lasting more than 5 minutes, what we call a status epilepticus. So epilepsy or seizures are in fact very common. That's the message I want to drive from this slide. So coming to classification, I'm not going into the depth of that. Probably you might have heard in older terminologies, grand mal, petit mal, simple partial, complex partial. Just for you to understand, all these terminologies are now outdated. Current ILAE classification, we have only 3 words as terminologies based on onset of seizure. You have to see how did the seizure start. So only 3: focal, generalized, or unknown. Each of them can have a motor or non-motor component. Under the focal category, the patient can have preserved awareness or impaired awareness. So in other words, previously used term called grand mal has become generalized now. Previously used term petit mal has become non-motor now. Previously used term partial seizure has become focal now. Previously used term complex partial has become focal seizure with impaired awareness. So these slides are available, so you can definitely go through them. I will not go to the expanded classification. That's more for neurologists. But for you as a physiotherapist, you should know seizures can be focal, generalized, or unknown. They can have a motor or non-motor component with or without preserved awareness. If this is more than enough for you to understand. Now, seizures are also classified based on their etiology. This is the current classification: genetic, metabolic, structural, infectious, immune-mediated, unknown. Now, an interesting question. What do you think is the most common cause of epilepsy, pediatric, adult, everything combined together in India? What do you think? You can type in the chat box. What do you think is the most common cause of epilepsy, pediatric, adult, everything combined in India? You can let me know as soon as you get any response. No problem. We will wait.
Doctor, most of the answers are coming as genetic. Is it audible, doctor?
Yeah. I can hear you. Any other response?
Okay. Most are telling us genetic. Some say metabolic. One person answered unknown.
Okay. So I trained at AIMS New Delhi. We have 10 on-calls per night, every night, per month. So every night we will see seizures coming to the emergency. If you get CT scan, you will find a ring enhancing lesion. The most common cause in India, even now, is neurocysticercosis, infection due to the cyst. Have you heard of this entity, Mr. Bala, as a physiotherapist? Like, yeah, just wanted to understand, like, whether physiotherapists know are aware of this entity.
Sorry, doctor, this is first time I'm hearing.
Yeah. So basically, it's a cyst which occurs in the brain secondary to a worm infestation by eating the eggs of that worm. It's called neurocysticercosis, and we call it NCC. Basically, that comes under the category of infection. In fact, that is the most common cause of epilepsy in India. So we can have so many causes like genetic, for example, one of the common condition, tuberous sclerosis. It's a common neurogenetic condition causing epilepsy. Metabolic, there are so many inborn errors of metabolism which cause epilepsy. Structural, you all know, all those causes which like hypoxia insult, hypoglycemic insult, brain malformation, so many causes, right? They can cause epilepsy. Infection is what I said, neurocysticercosis or meningitis, encephalitis, sequelae. Tuberculous meningitis is still prevalent in India, causing epilepsy. Immune mediated is now recently recognized causes. Basically, it is secondary to an immune mechanism which can cause epilepsy. By and large, even after extensive evaluation, 40% of patients will fall under unknown category. So I would encourage you, if you get time, just Google what is neurocysticercosis or NCC, and you can know more about that because it's very, very common in India. Okay, so now I will skip this. So because you are not going to take a detailed history, but you need to take confirm whether it is seizure or not, take the description of the events, ask the parents whether they have taken a home video, and ask their perinatal history, history of brain injury, infections. Family history of epilepsy is very, very important. Any treatment history and any comorbidities like developmental delay, vision, hearing impairment, autism. So this is what we do whenever a child presents with seizures. Now, whenever a child comes to us with seizure, we should take three accounts. Account from the child, which is often not taken. Account from the parents. Say a seizure, a child had a loss of consciousness at the school. Parents are not there at the school, right? So they must be giving a third person's account of a teacher or a friend. I always call the parents. I always call the teacher or the friend who witnessed and try to find out what exactly happened. So you need to have the account from all these three persons, child, parent, and eyewitness, to make sure what are you dealing with. Nowadays, home videos are available. So excellent. We even have CCTV camera seizures. So try to get the seizures. My message to you as a physiotherapist, if you find some child having a suspicion of seizure, tell the parents, please take a video and show to your doctor next time you visit the doctor. Make sure as a message you tell this to the families, because families often does not know this simple step. So if you feel a child is having a suspicious seizure event, tell the parent, take a home video and show to the doctor and confirm is it a seizure or not. That's one of my take-home message from you.
Mr. Chandramohan, I think it is not moving.
Yes, sir.
Voice of doctor is not available.
Yes, sir. Can you please call him? Dear participants, kindly wait. Maybe some signal problem or internet interruption from our resource person's side. So kindly wait. Meantime, you can keep writing your queries so that we will be reading it at the end. And there will be sharing of Zoom link in the WhatsApp group which I have created for this webinar. And also, many of you have not joined using the link which we have provided in the Google form for the registration. Kindly from next time, if you have not joined in the WhatsApp group, let us know and join in the WhatsApp group to get the feedback form so that those who fill feedback form can receive the e-certificate. And also now, I request all the participants give your attendance in the YouTube comment section. Yes, sir.
Chandramohan sir, I call the doctor. He is connecting, having some trouble in internet.
Yes, sir. Yes, sir. Yes. Once again, I repeat.
And
to
also,
our
he is
audience.
preparing to post the videos also.
Yes. Whenever we send the Google registration form, we will have the WhatsApp group link in that. Kindly join that group so that you can get the feedback link. If you don't get the feedback link, that is because you have not joined the WhatsApp group. Okay, then e-certificate will not be provided. So for that e-certificate, the registration is also mandatory. We will give the registration number and you have to put that registration number in your feedback form. Yes, sir. Over to you, sir. Sir, have you ever treated any seizures cases, post-seizures cases in your center? Sir, Balachandra, sir?
Yes, sir, asking.
Yes, sir. I'm asking you, have you ever treated kids who had seizures and then referred to physiotherapy? Have you ever experienced that kind of cases in your center, treating him?
I am seeing children with cerebral palsy. They have seizures. So I just refer to neurologists, and nowadays pediatric neurologists are available, and they are treating. Monthly once, Dr. Ranjith Kumar sir is coming here to Trichy.
Okay.
So we have most of the children with epilepsy. I think around 40% of the children with cerebral palsy in my clinic have epilepsy.
You have started screen share.
I hope that after this webinar, even our physiotherapists can meet the neurologist or pediatric
Chandramohan sir, I
specialist.
think Dr. has joined.
Yes, sir.
Sorry
Yes,
for
sir.
the technical interruption. The power went off for a moment. No problem. Yeah.
No
So
problem.
is it back now? Clear?
Very clear, Doctor.
Okay. So now I'm going to show you a set of videos which are like from children. Just tell me what do you feel this event could be, and do you feel it is seizure or not? It is very important. Some of them could be little beyond your expertise, but I feel as a physiotherapist, it's good to know these events. So this is a newborn on day 5. Parents are extremely anxious with this event. Happens only during sleep. What do you think about this event? You can put it in the chat box.
Sorry, Doctor. 1 minute, Doctor. The video is not playing here in the YouTube. Mr. Chandramohan, sir.
Sir, it is playing, sir. Let them watch it. It is playing. So in YouTube, it will play for 20 seconds. So we just wait for it.
Okay, okay. There is some delay between the Zoom and the YouTube, I think, sir.
Okay, sir. I will wait. No problem. Let them think. I will replay the video also.
Still, it is not
Meantime, I would
connected.
like to ask sir that do you refer cases, sir, post seizures to physiotherapy department? May I speak to Ranjith Kumar, sir?
Yeah, sorry.
Do you refer the cases, post seizures, kids to the physiotherapy department, sir?
No, very often. Most of them have tonal issues, cerebral palsy, motor abnormalities, hemiparesis. Of course, a lot of them. Not all, those who have motor issues and tone abnormalities.
Now it is connected, doctor, or connected to the YouTube. I think now we can play the video, doctor.
Okay, I will just think again. This is just a 5-day-old baby. Currently, the video is not playing. I will play the video. And the parents are extremely anxious with this type of events, which happen only during sleep. And tell me, what do you feel? You can put in the chat box. If there is any response in the chat box, let me know, Mr. Bala. And it is good if you can quickly, fast fingers. We don't have much time. Yeah. You can notice that child is sleeping nicely and nothing is, no autonomic imbalances. Any response so far?
No responses, sir. We can keep continuing, sir. Response will keep on coming. So we can, after 2 or 3 minutes of explanation, we can take it again.
So while someone is typing the response for this one, let me put this video. This child is awake, lying on the bed, and see what is happening to this child. And what do you feel about this one? You can tell us. Do you think it is a seizure? If so, what? You can see the child is awake. Do you see the jerking, Mr. Bala?
See the
one
just the
response
lower
has
lip.
that doesn't
Yeah.
seem to be a seizure. And another response has come that neonatal sleep myoclonus.
Excellent.
And myoclonic
So,
seizures.
yeah. Excellent. So congratulations to the person who put neonatal sleep myoclonus. This baby, this is not seizure, this baby. So this baby's event is just a sleep myoclonus, and it happens only in sleep and goes off by 3 or 6 months. It is not a seizure. No need to treat this entity, but it is good to confirm from the doctor. On the other hand, this baby, awake state, it is happening. This baby is a myoclonic seizure. So I put these videos side by side. Both are myoclonus, but this one on the left is a seizure. This one on the right is not a seizure. So same phenomena can be a seizure, may not be a seizure, depending on the age and presentation. That's the message I want to convey from this slide. Excellent to those who answered.
Responded as, sorry to interrupt you, you have responded as infantile spasm.
No, it is not infantile spasm. I'm going to show infantile spasm video, which is very, very important for a pediatric physiotherapist to recognize. I will show that. Anyway, good response. Okay. Now, please concentrate on this baby, the baby on the right, who is wearing a pink shirt. What do you think this is? Okay, while we are awaiting the responses, I will explain what is happening to this baby. This baby is a 9-month-old baby, pre-morbidly normal development, but presented with these abnormal clusters of flexion of head and trunk, whole body, little bit slow like this, occurring in clusters, most often after awakening. Parents didn't think it is abnormal for 2-3 months, and they found it is happening kind of going on for weeks. That's when they thought it is abnormal, and they brought that to the attention of doctor. What do you think this event is? Any response so far, Mr. Chandramouli? Mr. Bala.
Delayed milestone, they say, and spasm, they say.
Excellent. The video which I showed is called infantile spasm, previously called as salam spell. It is like salam. So this is often missed by parents as seizure. This is a seizure. This is very, very important to recognize. Even physiotherapists may not recognize and say this could be normal. I have seen it happening. It is very, very important to recognize this abnormality because delay in treatment can lead to ultimate outcome delay. For example, in other words, every 1 week you delay the treatment of this condition, the intellectual quotient, IQ, will come down by 5 weeks, 5 points. Often, we find there is a delay of 2 to 3 months in recognizing condition. So, while you are doing physiotherapies in your clinic, if you find a child doing like this, particularly 1 or 2 year old baby, think it is not looking normal to me. Is it a spasm? Refer them to a pediatric neurologist or whoever is the best person available for you. Get an EEG done and confirm. We get an abnormal EEG finding called hips arrhythmia in this condition. And this condition has to be considered like serious condition and treatment should be started as early as possible. Because we always tell the parents, when the spasms are continuously happening, your physiotherapy is not going to work. Correct? So first, these spasms or seizures should be treated or controlled. Then only your developmental therapies, physiotherapies, occupational therapies, neurodevelopmental stimulation will work. That is the most important message I want to convey here. This picture I am not going to play just to show how we do a video EEG. EEG is running with the video. These conditions can be picked up by doing a good video EEG. Okay. One more event. This baby is developmentally delayed baby, comes with this highly abnormal looking phenomena. So you saw 3 clusters in 1 minute. Okay, while we are awaiting response for this, I will play this video. Tell me this one is seizure or not. The one on the left, and what do you think is the name of the seizure? Another one baby is there in the middle. Tell me, is this seizure or not? If you know what is this, you can also type in the chat box. And the third one, this is a girl who often does this phenomenon in the evening, only happening in awake state, doesn't happen in sleep, and the parents can distract this from happening. You can see she's keeping both the legs crossed, tight like this, almost like scissoring. But she's completely alert and active and responsive. Okay, any responses so far?
One response, doctor, it is prolonged seizure. Another response is decortical rigidity, like that.
Okay, good responses. So first, let me tell you, the middle one is not a seizure. Baby is completely active, alert, just shaking. This is called shuddering attack. It is available in my YouTube channel also. You can see. Shuddering attacks are common developmental phenomena. Just needs reassurance. As the baby gets old, they go off. That is a normal thing, like a stereotyping. This is called gratification behavior, something like a masturbatory behavior. They get pleasure by rubbing the genitals. in this age. And this also goes off over a period of time. This is not seizure. On the other hand, this baby, in which you saw this event, which happened in like a cluster-like event, this is a special type of spasm called tonic spasm, which is like highly abnormal, and this needs referral and treatment. So this is spasm. These two are not seizures. So it is important to recognize which is seizure, which is not seizure. In case of doubt, better to refer and get it confirmed. That's what I'm trying to convey from these 3 slides. All the 3 looks quite different. It's difficult to pick up which is seizure, which is not. Better to confirm. So I will skip this part. Now you see this one and tell me what you think this could be. A child is just crying and see what is happening.
Yeah, Sunday. Well, Nisande. Vanda, Yerikupa. Yeah. Sandma. Sunday.
Okay. Any responses so far?
Responses, sir.
Okay.
No,
So this is not a seizure. The child started crying. Any response?
no response, doctor, till now.
Yeah. So this is not a seizure. Child started crying, and then you can notice the child's breathing stopped, and then developed a seizure.
Sunday.
This is what we typically call as breath holding spell. Breath
Somebody
holding
has
spell.
responded, sir. Absence of seizure. This is not a seizure.
Correct. Anyone respond as breath holding spell?
Not breath hold, sir. It's an absence of seizure. And a few said hypoxic ischemic encephalopathy. It's not.
No.
No. I think
But still responded. Good.
I think there is no good response, doctor. I think
So it's a very, very important message. It's important to recognize. Often the parents will come to you and say, the baby cried and became unconscious. And this can be taken as seizure. No.
This is more common, doctor.
Very, very common. So ask the history. Does it happen with crying every time? Over daravai mein algam bolda varda. Har bar rote waqt hota hai kya? I'm telling in all the 3 languages, because we get all the types of patients. If it happens every time starting with the crying, cessation of breathing, and you have to think, is it breath holding spell? Iron deficiency anemia is very, very commonly associated with this condition. You just have to reassure the parents, check the hemoglobin and start iron. Often I have seen these children being mistreated as epilepsy, and they may come to you. They think you are also a doctor. They may ask you, in the medicine, this medicine is going on. Is it correct or not? I feel as an allied health professional, which we do with the intention of do good to the patients, you can always say, what do you feel? You feel it could be breath holding spell. Please reconfirm with your doctor. I do see a lot of children with breath holding spells mistreated as epilepsy.
Excuse me, doctor. We all physiotherapists generally refer to neurologists nearby.
Okay.
And nowadays we are very fortunate to have you specialty coming here periodically. Thank you so much, doctor. Now the parents are very happy from my clinic. I can see from the parents. Another thing I just want to convey to all the physiotherapists here that I'm very happy nowadays that in any time Dr. Ranjith sir is available and the parents communicate directly online. Doctor is available online also consultation. So thank you so much for the doctor, because all the of epilepsy I'm seeing in the children here, and every parents are diagnosed properly and they're following the medications what you are prescribing nowadays. Thank you so much for the doctor.
Okay, thank
And
you very
also
much.
for the online consultation, very, very useful, doctor.
Yeah.
Because otherwise the parents will get more anxious.
Exactly.
Thank
Okay,
you.
so
Thank you.
yeah, so you can tell me if the time is limited. I have so many slides. Please feel free, Mr. Chandramouli, to say 5 minutes before to stop. I can stop those videos. This is one thing which I wanted to show you.
We can have another 30 to 40 minutes session.
Yeah, just tell me 5 minutes before when I have to finish. Okay. So this baby presented with these abnormal movements after taking feeds every time. Baby is 11-month old. And this was thought whether it is a seizure. And this is one study which is being shown here, but let us see how is the video. So I will describe what is happening. This is called arching of the back. In other words, you call this opisthotonus. And you can also see the neck is extended like this, like a retrocolis posture. Baby is a little bit uncomfortable. The parents have just fed the baby. And the baby remains conscious only during this episode. This is not a seizure. We did a barium swallow study and we found reflex. So this is a gastroesophageal reflex, which can present like this in children. Very, very common condition. So even non-neurological conditions like this can mimic such things. So it is often important to recognize and treat accordingly. Okay. I want to show you this one very, very
Excuse
important.
me, doctor. Excuse me, doctor. I think that YouTube, there is some delay in connectivity.
Okay. We'll wait for a moment. No problem.
Now only the previous video, the opisthotonus posturing is connected here. Could you please explain again about that arching opisthotonus retrocolis position, doctor?
So this baby is having arching of the back. This is called as opisthotonus. And the neck also extended back. This is called retrocolis. And this happens often after taking feeds. And we did a barium swallow study and we found reflex into the esophagus. So this is nothing but a gastroesophageal reflex causing seizures. This is not epilepsy. So message is, even other conditions which are not neurological can lead to some abnormal phenomena which mimics like seizure. So they are called seizure mimics. There are so many seizure mimics in children. Okay. Next, one video which I feel everybody who is in the medical profession should see. Just to see this video carefully. The parents is a school-going child. Parents came to us with a complaint of multiple episodes of vacant stare. And the teacher asked the boy, why are you daydreaming? And the teacher scolded the boy. You are not listening to my class or school. You are daydreaming. And he came to us. The parents said, it is what is happening. We did what is called as blowing the paper, hyperventilation test, bedside, and tell me what is happening. And what is this? Right. And the paper bottom. So you all noticed he was blowing and suddenly he stopped blowing. He became a little bit unsteady. He was vacant, not responding. And then he got back to normal and even started blowing back. Vacant stare spells. Can anyone tell me what is this seizure type called as? I will wait, no problem. While they are typing, I want to show this laughing type seizures, which we call as zelastic spells. See, that's a seizure. It's a laughing seizure. Okay, any response to this boy's events?
No response, Dr. Till now. One person answers as dyspnea, another as absent seizures.
Excellent. Excellent. So this is the classical absence seizure. We call it childhood absence epilepsy. Easily treated, just one medicine. The laughing seizure is called gelastic spell, and we often provoke seizures in our EEG by asking the patient to do hyperventilation. And you can see this one interesting seizure type. The patient is hyperventilating. See, he is hyperventilating. His eyes are still closed. Now eyes started opening. Eyes become broader. Eyes become so big. He is vacant stare, not responding. Now eyes are slowly deviating towards the right side, and face is also deviating towards the right side. He doesn't have any GTCS or tonic-clonic seizure. So often, laymen, that is general people, will think seizure means seizure like this, jerking of all the things. No, you can just have eyes open and going towards one side. So this is called as focal seizure with impaired awareness. This event is exactly called as version, VERSION, eyes going towards one side. These are all often misdiagnosed by parents as like not looking like seizure, right? None of them look like jerk. So these are all missed by parents. I want you all as physiotherapists to recognize these events, which are very suspicious, and refer appropriately. These are all seizures, which does not have convulsion. So the message is, not all seizures are convulsive in nature. Okay, so sometimes you can have dramatic drop attacks, sudden drops and getting hurt. So look at this baby. The parent is even holding her so that she won't fall. They know she's going to fall. She's becoming unstable.
Playing music? Set up professional audio and audio settings. Close. Press CMD plus to open pop-up.
Did you see? Tonic drop attack. Look at this child.
Sorry, doctor. I think there is a delay in connectivity.
Okay.
Still, the video is not playing in YouTube.
Should I play again this one?
1 minute, doctor. The previous video,
Yeah.
that version is only available in the screen now.
Okay.
I think there is some delay in the speed between the Zoom and the YouTube. The video is running there.
Can I play now?
1 minute, doctor. Still, it is going. The previous video is going there.
So keep engaging the participants meantime, so that
the videos which I am going to show now, these are called drop attacks, drop seizures. They can have different pictures, videos. Shall we play now?
1 minute, doctor. Now it's okay, doctor.
Yeah. So you are going to see three different drop attacks. See, he went forward like this. So this is called head drops. I will play again for you. Head drop. Look at this baby. Tonic drop. And now look at this dramatic video. Atonic drop. So any child who suddenly drops or falls like this, these are also seizures. So often not recognized by parents as seizure. They may just think child is falling. Okay. And sometimes we will just see one side jerking. That's it.
1.7 mg மட்டும் எடுங்க sister.
Focal jerking of the angle of mouth, seizure. Okay, now very interesting video. Is it playing, Mr. Bala?
Excuse me, doctor. There is some delay.
Okay, I will wait. So I'm going to show you one interesting video. This often happens in sleep in this child, and the parents are extremely anxious. This child has autism and developmental delay. Okay, autism and developmental delay.
Excuse me, doctor. There is delay in audio also.
Okay.
The previous video, the 3 videos are running now in YouTube.
Okay.
The head drops is going there.
Okay.
In YouTube.
Okay.
Around 1 minute delay is going there, doctor.
Okay. Okay, fine. So let's move forward, because I'm not going to ask any questions to interact now. I will just explain now. That should be fine.
Audio is also not parallel. It's completely audio and video. It is delay between Zoom and YouTube.
Okay. 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 So one last video. Can I play? This will be the last video.
Yes, sir.
Okay, doctor. I think it will connect. Maybe
Yeah.
there is a delay between Zoom and YouTube, so I can't see both together.
Okay. I will just play this one last video. Child with developmental delay and autism and doing this. All physiotherapists should know this. Seizure or no seizure? So this is not seizure. This is a behavioral stereotypy. We call it stereotyped movement. So we have to recognize which is a stereotyped movement versus seizure. What is a stereotyped movement? Stereotyped movement are patterned repetitive movements which happen in children who have autism and other neurodevelopmental delay and disorders. Very important to recognize. They don't occur in sleep and they can be distracted easily. Probably I will skip all these videos now. One more video I just want all of you to know. Often you see in adolescents and young middle-aged women, psychogenic non-epileptic events. Psychogenic, functional cause. That I do what you called as inducing in my office room, chamber. We use the tuning fork and say at the 10th second the seizure is going to come. They will do that. You can see what is happening to this girl. I'm just doing that, acting. 4, 5, 6, 7, 8, and 10. I'm inducing the event. Now she's going slowly becoming dizzy. Eyes closed. Whole body jerking. Not falling. Not getting hurt. Important message. All seizures, usually eyes are open. Eyes closed means syncope, not seizure or functional psychogenic. Very, very important message. You can see the whole body jerking movements without falling, without getting hurt, eyes closed. This is not a seizure. This is a psychological, psychogenic event. Okay. One more important videos you should see. Adolescent girl, daytime normal, but often does this in sleep. Parents will very scared. This is happening in sleep.
Back. Back.
Seizure or no seizure? This is not seizure. This is a movement disorder in sleep. Rhythmic movement disorder in sleep. There are several movement disorders which can happen in sleep. So it is important to differentiate between a seizure and movement disorder. So basically, by all these videos, we have seen different phenomena happening. Some of them seizures, some of them non-seizures. The main message is very, very important to recognize which is seizure, which is not. And if in case of doubt, early referral and early treatment. So I will skip the rest of the things, and often we get the videos from CCTV camera also. Nowadays CCTV cameras are very useful. So I wish you have CCTV cameras in your clinics also, so that you can capture several seizures. Okay, so I'm skipping all these things because this is not for you. And we do MRI, EEG, all those things, and investigation, diagnose. This is EEG is the key tool in the diagnosis of epilepsy. I will skip those parts. You know all these things. And very important message I want to convey from this. I have a YouTube channel. Every parent should be educated how to manage seizure at a home. They often travel, take the child from their home to your clinic. Seizure can happen on the way also. Seizure can happen in your clinic also. You should know how to use. So you have something called midazolam nasal spray, which can be used as a nasal spray to stop the seizure. You don't even need to give an injection or just a spray. It is available in my YouTube channel. I will share the link to Mr. Bala, and he can share to all this thing. All the physiotherapists should have this at their clinic, those who are dealing with children, and should be able to manage seizures in their clinic. So treatment part I will skip because we all know. Yeah, this also I will skip. Yeah. Most important is counseling of parents, which we do. We also give booklets and seizure educational information. We do advise them what to do when a seizure happens at home, explain them at what is called as recovery position. Often, parents give keychain, hammer, metallic objects. They don't work. It's just a myth. So it's very, very important to educate them. So these are our brochures. So I just want to give you one more message. I went to Canada to learn advanced epilepsy management. So with one medicine, 60% of children can be seizure-free. With two medicines, 70 to 80% can be seizure-free. Even with third medicine, fourth medicine, sixth medicine, some children remain uncontrolled epilepsy. Those uncontrolled epilepsy are called refractory epilepsy or drug-resistant seizures. Daily seizures, monthly seizures, 3 medicine पोगुது 4 medicine पोगुது 2 दवाई चल रहा है 3 दवाई चल रहा है फिर भी seizure control नहीं हो रहा है. After giving many medicines also seizures are not getting controlled, not cured. These are called drug-resistant epilepsy. For them, we have several other treatment options called as epilepsy surgery, keto diet, vagal nerve stimulation, So we are doing that kind of advanced epilepsy care in what we call as SRMC, Advanced Epilepsy Center, where I work. And our goal here is to cure epilepsy. Epilepsy surgery is cure, whereas anti-seizure medicine or control. This distinction you should know. If any patient has a refractory uncontrolled epilepsy, I would say it is the role of the health professional to refer them to proper epilepsy centers. I will stop this, and we celebrated our World Epilepsy Day, epilepsy surgery child, 1 year seizure free, and they do absolutely normal walking. I want to tell about this boy. This boy is from Pattukottai, which is rural Tamil Nadu. He has a hemispheric epilepsy due to hemispheric cerebral palsy. One side of the brain got scarring at birth due to some reason, stroke. And from that scar, he continues to have seizures daily. And because of that, he developed hemiparetic CP and epilepsy. Multiple drugs not working. Then we did what is called as hemispirotomy. You can see here. Hemispirotomy is a procedure.
Santosh G has joined the meeting. Sabu
where
Malik
we
has joined
disconnect
the
one
meeting.
hemisphere from the
Intusargar
other
has
hemisphere.
joined the meeting. Utters Gajendra Mahapatra has joined the meeting.
Yeah.
Sabu Malik has left the meeting. Jiffy Jifdr has joined the meeting.
Okay, even after you disconnect with good physiotherapy and rehabilitation, you can see the child is walking. See, he's walking after the procedure, hemispirotomy procedure. But still one hand is hemiparetic. So for rehabilitation following epilepsy surgery, we need the help of physiotherapists, long-term rehabilitation. This child, in fact, recently received Botox to his forearm hand muscles also. Just last message, even there are patients who doesn't get controlled with keto diet and they are not good candidates for epilepsy surgery. For those patients, we do what is called as VNS, vagal nerve stimulator. This is a stimulator like a pacemaker placed under the collarbone, and the lead wires are connected to the vagal nerve. And we stimulate the vagal nerve, and thereby it is controlling the epilepsy. These are some of the advanced care we do at our epilepsy center. And this is my book, Mr. Bala already mentioned. If anybody interested can buy this book for pediatric neurology. It's available in Paras publications, if anybody is working in that. So my contact details, this is my contact details. Anyone can send me a WhatsApp message or email, anyone interested, or follow my YouTube channel or my Twitter account. Feel free to connect. So I always wanted to take all the stakeholders involved in care of children, physiotherapists, occupational therapists, or developmental therapists, or like other allied healthcare professional, because without you, we cannot help the child. So it is not only the doctor, it's all the other professionals who are involved in the care of neurologically impaired or neurologically disabled children to make their quality of life better. So feel free to connect anytime. We are ready to help in any time and open to questions. And probably we are going to the live session, right? Yeah.
Yes,
You
sir.
have stopped screen share.
Posted the YouTube, the Zoom meeting link in the WhatsApp group and also in the YouTube. Those who have doubts can directly talk to our resource person now by joining the Zoom meeting. So
They can turn on their
I have
camera
a
also if they want. Yeah.
Sir, most of the people are living in rural areas, in the villages. Okay, there they will not have the chances of meeting immediately a neuro specialist. Okay, is that okay to meet a medical assistant immediately, whoever is available there, MBBS or anyone available in that? Whether we have to go to neurologist only immediately?
No, sir. We are not like emphasizing on that neurologist only they should go. But it is always good to seek a general medical help first. Wherever possible, they should be referred to the appropriate specialist. So it is always good to first connect to a general what do I say, a medical practitioner or a general medicine person or a pediatrician, and they should refer. I definitely understand the concern, but in this era, as Mr. Bala was saying, online has become a big success in India, online consultations. I would feel if the patient is not able to reach, a physician there then can connect and do telemedicine with us. In fact, I have done few telemedicine with Mr. Bala, I think. So we do telemedicine with across the world, in fact. So anybody can connect online. My message is first connect to the general practitioner, and whichever possible is the nearest center. If you feel that's an appropriate case to be referred, better to refer.
Yes, sir. Thank you, sir. There are some questions.
And those
Bala,
who are
sir,
having refractory and multiple seizure should be referred yearly.
Yes, sir. Before Bala sir is searching for that, I will read a question, sir.
Correct.
Are febrile seizures common in developmental delayed child?
It is very common in children. 1 in 20 children have febrile seizures, 5%. It's not unusually common in develop. I feel the prevalence is same. So it is not much different. But if children with developmental delay have febrile seizures, we have to be a little bit more careful. Is it just epilepsy or febrile seizures? So we need to evaluate them. Sometimes they can have epilepsy, which gets provoked with fever.
I request the Zoom meeting audience kindly switch off your videos, please. If you want to talk to our resource person, kindly switch on, and then also your mic unmute, then talk. And there is a question in the chat box, Zoom meeting also, I think. So can you please tell more about awareness about epilepsy? I suggest Santosh, you just go through this channel again, and Sir is also having a lot of videos. Kindly go through that. And I request Bala sir, can you check any questions in the YouTube?
For that, Mr. Santosh, I have a parental education video on epilepsy in children in my YouTube channel. You can go through that. And we do yearly annual epilepsy awareness program. And we give so many talks in so many forums. So enough awareness activities we try to do. But actually, this event is one of the awareness activity which I wanted to bring in. So I am an epileptologist. So I am extremely keen on bringing more awareness. And I feel all the stakeholders like you, physiotherapists, are one of the important partners in this mission.
Sir, I would like to ask a question.
There are some questions in the YouTube, doctor.
Go ahead.
Sir, can you able to give the categorization that you have said about the grand mal, petit mal comparing to the new classification?
Yeah, so just remember 3 words: generalized seizure, focal seizure, unknown onset. Each of them can have motor or non-motor component. With or without awareness will be there in focal seizure. So for you, I would say, just remember these 3: generalized or focal or unknown. Those older terms, grand mal, petit mal, complex partial, simple partial, are no longer used.
Okay, sir. Thank you, sir.
May I read the questions in YouTube, doctor?
Yes, yes.
One question: how to differentiate between seizure and sleep movement disorder by Aguila Kameshwari?
Yeah, so it's not easy, but generally speaking, sleep movement disorders does not impair awareness, does not affect the next day performance, does not cross frothing, salivation, or like tiredness or injury. And the most important thing is it's not easy to differentiate as a general person. So the best way is to do a detailed history and examination, watch the videos. Often we do what is called as video EEG and capture them. Sometimes both of them can be interchangeably confused. So it's always better to kind of take a detailed history examination, see, look the video, if required, do a video EEG and confirm, I would say.
Another question, doctor.
Yes.
In any emergency or any kind of seizures, can nasal spray be used?
Please watch my channel, Ranjith Kumar Manokaran. I would encourage Mr. Bala to share that YouTube. I will send it to him. That everybody should watch that video. It full.
Definitely, doctor. I will.
Yeah.
We have
The
a WhatsApp
answer to
group,
that
doctor. We
question
will
is there in the video. Yeah.
Definitely, I will share in the WhatsApp group what we have created for this webinar. Another question is, will hypometabolism be a cause for epilepsy? From Kabilan.
Yeah, the context is not that clear. Hypoglycemia or hypometabolism? Like a lot of hypometabolism, right?
Yes, yes.
Yeah, so we have so many inborn errors of metabolism in children. We call them as amino acid metabolism disorder, protein metabolism disorder. Lot of metabolism disorders can cause epilepsy in children. So for example, you might be hearing condition called phenylketonuria. That's an amino acid disorder, can cause epilepsy. There are many conditions can cause epilepsy, metabolic disorders. Yes, true.
One question from Deborah. How does one get history from parents regarding seizures if parents don't know what they are looking at?
Correct. Excellent question. So first time when a parent is witnessing a seizure, they will just describe what they saw. Next time, we will give a detailed what we call a seizure history form, which contains all the information, what to look for, is there any one deviation towards the one side, frothing, salivation, urination, duration. We also ask the parents to maintain a seizure diary. So we don't expect the parents to give all the information first time. Sometimes the information is not that much collected. But those children who have recurrent seizures, we in fact tell the parents what all to look for and come to us next time. And obviously, you know, we ask them to take a video. So that's a good question. Yeah. But we try to retrieve as much as information as possible from the parents.
I have followed a question, doctor. It is from Epilepsy Foundation of USA. This is the questionnaire for parent of a student with seizure. I have a form, doctor. I will share with you, doctor. This we are following in our center. Here they have details about the epilepsy, type, length, frequency, or the description like that. So please check and let us know whether we can follow this checklist questionnaire.
Sure. Excellent.
It is a questionnaire from Epilepsy Foundation of America.
Sure. Definitely. Please share with us. And there is one question in the chat box. They asked, do absent seizures occur in pediatric population? In fact, it is more common in pediatric than adults. So we have an entity called childhood absence epilepsy, which occurs in 5 to 10 years age of children. It's very, very common.
A lot of questions are coming.
There are other questions. Yeah.
What you can do is you can theme the questions.
Okay.
Like need not be repetitive questions. Like you can find out what is the common theme in those questions and all those themes. Yeah.
Yes, like that only. Do all types of meningitis have seizures, focal seizures particularly?
No, meningitis can present with fever, altered sensorium, or lethargy or tiredness. Sometimes they can have seizures, not all. But encephalitis commonly presents with seizures. Meningitis means only meninges, dura, mater, arachnoid mater, leptomeninges. Encephalitis means even the brain got inflamed. In fact, in Trichy, Japanese encephalitis is very, very common. You should advise all the local members to get vaccinated for Japanese B. I am seeing a lot of Japanese B encephalitis.
Would seizures or epilepsy be seen with symptoms of headache or vision disorders?
Very good question. So migraine is one condition which is commonly present with recurrent headaches. They can coexist with epilepsy. Common. Sometimes visual symptom as an aura, what we call as aura, the pre-symptom of seizure, can occur because of occipital lobe epilepsy. Occipital lobe is the lobe which is behind the brain, right? So visual seizures are also known. One more thing, there is a special epilepsy called photosensitivity epilepsy, in which flashes of light, like a video game or a cinema hall, they can also cause epilepsy, seizures.
Is the seizure completely cured? One question.
Usually seizures are controlled with anti-seizure medications. They are not cured. They either go into natural remission or they are cured by epilepsy surgery. Correct? So you understand what I'm trying to say? They can either go into a natural remission. The medicines doesn't cure. They can get naturally remitted on its own. For example, childhood absence seizure, 5 years of age it starts, you give medicine that controls that absence seizure. But by 8, 9 years of age, it naturally remits.
Depending upon the type, doctor?
Depending upon the type, exactly. Suppose, I will give you an example. There is a scar in the right frontal lobe by birth. I mean to say the brain scar. And that is causing epilepsy continuously. It will remain always. It doesn't remit. But if you do an epilepsy surgery and remove that scar, that patient can be cured. One entity called juvenile myoclonic epilepsy, which we talked, it doesn't remit. It is lifelong treatment. So it is individual epilepsy type dependent question.
Sorry to interrupt you.
We have some more questions also, doctor.
Yes, sir. We will take another 7 to 10 minutes, sir.
Okay. Thanks, Mr. Chandramouli. Mr. Bala, I think you can go for common themes.
Okay. I'm just reading all the questions, doctor.
Yeah, quickly we'll answer them. Yeah.
Okay. Some questions repeated. One question from Kapilan. If hypometabolism of medial temporal lobe and cerebellum reported in the PET scan can cause epilepsy, will it be associated with increased anti-epileptic drugs?
I think this is an individual patient-based question. I would prefer you send me the details by WhatsApp message. We can discuss more.
Okay, doctor. I will just send all the details about you to the WhatsApp group members.
Yeah.
Hope they can answer. You can answer directly to the inbox, doctor, in the future.
Yeah.
It will be useful for the parents also.
Correct. Exactly. Yeah. Individual patient-based question we can answer individually. Yeah.
Sir, there are questions, sir. Can we immediately start the therapy after the medicine dosage? In case if the kid is going through medical dosages, so can physiotherapy can be done along with that? That's what the question, I think. What is the role of physiotherapist when the patient is undergoing the medication?
If the patient is having controlled epilepsy, no active seizures, physiotherapy can be safely done. If the patient has active seizures, first control the seizures.
Okay, sir.
Is it clear?
Yes, sir. Yes, sir. There is another one more question, sir. Whether cerebral palsy is the most common cause for seizure?
That is one of the very common cause of epilepsy in young children population, of course. But by and large, if you ask me, it's actually the neuropsychiatric which is more common. But cerebral palsy children have high risk of epilepsy.
One more question, the same related to the rural area. If they don't have any medical assistance in their area, the whole night they will be under trouble. So what can be done? Is it okay to advise in live program?
No. See, at home you can use the spray, midazolam nasal spray. Then you should try to go to the nearby medical emergency if it is not getting controlled. You cannot manage at home if it is not getting controlled.
They cannot leave the kid like that the whole night. So something should be done immediately.
If you leave the kid, if the seizure goes beyond 5 minutes, it can damage the brain. You have to go to emergency if it is not getting controlled.
Yes, sir. So there
I understand
2 more questions
area,
I will take.
Yeah.
Yes, sir. Please carry on. This is for the rural thing. Please carry on, whatever the
So
message.
I would say they should try to connect or contact the nearest health facility.
Yes, sir.
In Tamil Nadu, we have excellent primary health care. I don't think that problem is every district has a medical college. Every village has a primary health center. I don't think that problem will happen in Tamil Nadu, but not sure about other places. Yeah.
Yes, sir. We will be taking
one
another
question,
3
doctor.
questions.
May I ask one question, doctor?
Yes.
Please carry on.
A common problem during emergency. the parents are waiting for the seizure to stop by its own because the child is already in medication. But if the duration is prolonged, it is going more than 2 minutes or 5 minutes like that. At what time they have to get ready to go to the hospital? Maybe.
Yes. If the child is a known epileptic, already known epileptic child, parents can manage at home. If it is crossing 2 minutes, 3 minutes, they can give the midazolam nasal spray and see it stops. If the child recovers, they can go next day also to meet the doctor. If the child has continuous seizure, which is not stopping even after midazolam in spray, or cluster of seizures, which is out of proportion to the usual frequency, they better go to the hospital.
Midazolam can be used only once or twice?
Sometimes we repeat. Sometimes we repeat, not more than 2 times, because it can cause respiratory depression. Not more than 2 times. Okay. So that link, the video has all these questions related to midazolam.
Okay. One common practical difficulty is when we go to the near hospital, they start a new type of medication, which is not with parallel to the previous medicines. They continue for some time, and then they are not able to follow. They have got the confusion which one we have to follow. This is a common problem I am facing from the parents, doctor.
It's an excellent question. For my own patients, I always give a plan, written plan. What if an emergency happens? This is the first step. This is the second step. And you go and show that plan to the nearest health facility so that they can follow that plan. So that they won't think what next, so they can follow our plan. So the neurologist better give a detailed plan. What are the first choice, next choice, third choice in that situation?
Thank you.
Does it answer your question?
Yes, doctor. Yes, doctor.
Yeah. Someone asked, does the aura happen in children? Definitely. Children who are more than 5 years of age will be able to describe the aura. Yes, we do see.
Doctor, we have a lot of questions. Is it possible to share the questions to you, doctor?
In all these things, sir, I put it in one question. So the things is like, is pseudo seizures leads to epilepsy? And the next question is, nystagmus related seizures common in infants or in adults?
Pseudo seizure is not epilepsy. You should refer to psychiatrist and behavioral therapy should be done. Nystagmoid seizures we have seen in children. I am not an adult neurologist or adult epileptologist, so I don't want to comment on that aspect, but I can say it happens in children. Nystagmus as seizure.
And one or two questions are related to the patient's details that we can discuss. We will give the share
individual patient details. They can contact us. No problem at all.
Yes, sir. And yes, sir. Bala, sir. Hello.
Sir, 1 minute, sir.
Yes, sir.
Yes, sir. Yes, sir.
Yeah, please be on the screen. Yes, sir. Sir, we will be stopping the session here today. So we have other sessions starting by 9 o'clock, but we have passed it. So since we never stop, actually, we encourage most questions to get answered because our participants were in search of answers. So when the right person is there, we never stop, but we agreed to do one more program at 9 o'clock. So we'll be stopping here today, but sure, we will have one more session. And really, Ranjith sir, it is a wonderful session, very good, clear explanation and information. And I would like to thank at this moment for Balachandra sir. At right time, he has approached. Actually, we have other programs, but he said that, can we do it immediately? I said, okay, give the things. And you are also ready at other end. And thoroughly we all enjoyed, actually. When I go through the comment sections, there are a lot of praises on you. So once I will re-edit and we will post according to the rules of the YouTube. And I will give you the connections. You can also answer the queries in the comment section. Or if those whoever wants your number or email ID, we are happy to share. And if they need help for any kind of kids, they can communicate with you. And I would request Bala sir and Ranjith sir to have a word, and then we will sign off.
So before Mr. Bala speaks, so I'm extremely thankful to your organization and all the office bearers and all those physiotherapists who have joined today. I didn't expect this much participation, and special thanks to Mr. Bala, who is taking so much efforts and bringing all the, like even the medical specialists into their team. So yeah, so I think I did justice what I wanted to do. So my message is the health professional should try to collaborate as much as possible. Right now, what I see is these things are happening as silo. Physiotherapist means they will do only physiotherapy. Neurologist means they will only give medicine. No, we should all work together for the betterment of the individual patient. That's my key message. And thank you again all for patient listening and amazing participation and excellent interaction. And you all did great job today by answering all the questions.
Thank you so much, Doctor. Thank you so much, Doctor. It was a wonderful session. This is a long time I have been attending a neuro webinar. It was, we didn't see the time also. It went very fast, very interesting. And most of the questions what the participants asked helped us to have a good interaction with you. And it made us clear about epilepsy. And we would like to be in connect with you periodically. We kindly request you to spend time with us in the future also, Doctor.
Definitely.
And you're very fortunate, Doctor. Thank you so much for your valuable time. And that too, you volunteered and you came forward to teach the physiotherapists. So on all behalf of all the physiotherapists, I thank you very
Your audio is not clear, sir. Bala sir.
the time and ask good questions.
I think, am I audible, sir? Ranjith sir?
Yeah, you are audible. You are audible. Yeah.
Yes, yes, sir. Bala sir, you are not audible. So I will be continuing it. And well said, sir, Ranjith sir. I am so happy that there will be bridging always. We already had orthopedicians also presenting in our platform from Poland and some other countries also. We already had. It means that a lot to me that we are bridging the professionals to share the knowledge. We may not have a much more knowledge about medicine, and even the physicians will have a poor knowledge of physiotherapy. So it is best that if you bridge these things, the gap will be filled and we can be working as a team.
Exactly.
And I'm very happy that you came forward and you took a very nice session. And we would like to have 1 or 2 more sessions whenever it is possible.
I think we can do once, maybe after 6 months or so. Let's see.
Yes, sir. Sure. And we'll be signing off, sir. Bala sir, with your permission.
Okay, okay, sir. Okay, sir. Thank you so much, sir. Thank you.
Bye,
thank you, Doctor. Good day. Good night, Doctor.
Good night.
Bye, bye, sir. Good night, sir.
Good night,
Good night, Ranjith, sir.
Thank
you. Yeah. Thank you, dear participants. And we will meet after a wonderful session later. And upcoming webinar is 2 days pulmonary rehabilitation. I request you all to join and have a very good interaction with the resource person and learn more. Happy learning. Good night. Thank you, Bola sir. Good night.
Thank you. Thank you. Good night. Take care. Bye.